Hello everyone, I am Arnaud on behalf of my promoter Peeroz. I'll be discussing the topic of dysthyroid optic neuropathy or DON. Let's start off with some background information. DON occurs in about 5 to 8% of graves orbitopathy patients. The main risk factors are higher age. It has a higher male to female ratio compared to normal graves orbitopathy. Smoking is definitely a risk factor. The myogenic type compared to the adipogenic type. Stress, whether it be from infection, surgery, or psychological stress like the loss of a loved one or a divorce, for example. Diabetes, probably due to vasculopathy and hyperthyroidism. So pathogenically, several mechanisms have been proposed. Compression of the optic nerve at the apex, either directly, thus impairing exoplasmic flow, or indirectly through microvascular ischemia, seems like one of the most likely factors. The medial rectus lies most adjacent to the optic nerve, followed by the superior rectus, and enlargement of these muscles probably holds the largest danger to the function of the nerve. Stretching has also been coined in the past, although in 2020, Jeffrey Rose and his colleagues specifically investigated this mechanism, and they found that although optic nerve length, radiological proptosis, and orbital nerve angle were significantly higher, the optic nerve did not reach its elastic limits. And they concluded that for most patients, stretching of the optic nerve was not a causative factor, although it might render the nerve more susceptible to other forms of injury like compression or inflammation. Optic neuritis due to neighboring inflammation has also been suggested, although histologic examination of optic nerves of DON patients did not reveal any inflammatory infiltration. So patients with DON usually have a rapid onset of complaints. They occur bilaterally mostly, and they complain of blurring of vision and desaturation of colors. Clinically, we use several criteria to diagnose it, usually at least two of the following. The best corrected visual acuity, so mainly a decrease compared to the previous measurement. There's no perfect cutoff value. Color vision testing, Ishihara tests are less sensitive than a Farnsworth Hue test, but they are more practical. A recent study found that trident deficiency was very specific for DON and was in fact the earliest sign of abnormal function of the nerve. Visual field defects are mainly found in the central and paracentral area, often inferiorly. Optic nerve head edema is highly specific for DON, but it lacks sensitivity. And the same is true for an RAPD, especially in bilateral cases. And then finally, a pattern VEP shows increased latency and decreased amplitude, but it is time-consuming exam and it definitely is not always available. It should be noted that not all patients with DON show strong clinical inflammation. A UGOGO study found that about 25% of patients had a CAS of 3 or less. And there are no golden standard criteria. So we use these clinical criteria, but they're not golden standard. Imaging is often supportive. I think most clinicians probably use CT because it's readily available, fast, and it defines the bony anatomy very nicely, which allows for surgical planning. The downside of CT is the radiation. CT of the head administers about the amount of radiation that is equivalent to 5 months of background radiation. An MRI offers more soft tissue detail and the option of evaluating inflammation as well through diffusion-weighted imaging and short-tau inversion recovery sequences. The disadvantages are the availability and the bony anatomy that is less well defined, although it does allow for surgical planning. So many factors have been studied in the past. I think the factor with the most diagnostic value is the medial rectus diameter. It has been shown to be an independent significant predictor of DON in multivariable models. Some value probably also goes to severe apical crowding, whether it be categorically scored, or area or volume based. And also the thickness of the other EOMs have some value. And then many of the other factors are controversial. Some studies find they have some use or some diagnostic value, others don't. And also for the imaging, there are no definite criteria. MRI, as I said, allows for evaluation of inflammation. And in DON, it's been shown that optic nerve diffusivity and fractional anisotropy might play a role in the diagnosis, might have some value. And recently, we also studied the signal intensity ratio and relative apparent diffusion coefficient of the EOMs compared to the temporalis muscle. And we found that the medial rectus diameter, superior rectus and inferior rectus RADC, and the limitation of depression, so a clinical parameter, were independent significant predictors in 3 different multivariable models. Each 3 of them had a nice sensitivity, specificity, and positive and negative predictive value. So the management, DON is an emergency which should be handled by a multidisciplinary team in a specialized center. We should always strive for a euthyroid state and urge the patient to stop smoking. We should always avoid the use of radioactive iodine because that can deteriorate inflammation. And the first line of treatment is usually IV steroids, so methylprednisolone, 500 to 1,000 milligrams on a day on 3 consecutive days with daily ophthalmic monitoring. And after a week, we can check whether the patient can handle the treatment, if it can be continued, if so, and if there is a good response, we repeat it after a week. If not, or there is no or only partial response or clinical deterioration, we move on to surgical decompression. Now, surgical decompression does not provide a better outcome compared to IV steroids as a first-line treatment. So that's why I would start with IV steroids. The IV steroids are effective in about 40% of patients. We should avoid going over a cumulative dose of 8 grams for a patient. And we should definitely check for recent viral hepatitis or severe liver disease, severe cardiovascular disease, uncontrolled hypertension or diabetes, and psychiatric disease, because these things can definitely be deteriorated by the IV steroids. So before we start, we should check for the liver enzymes, viral hepatitis markers, fasting glycemia, a liver ultrasound, and check the blood pressure. And we should follow up the liver enzymes, glycemia, and blood pressure monthly. It's also wise to add a proton pump inhibitor and to think of osteoprophylaxis through calcium or vitamin D, and if necessary, bisphosphonates. So surgical decompression, the inferomedial wall is most closely related to the optic nerve, but often a combined decompression of the inferomedial, medial, lateral wall, floor, or fat is performed. The results are independent of the previous use of IV steroids or radiotherapy, but they are dependent of the extent of decompression. So surgical decompression results in a reduction in proptosis, eyelid retraction, and orbital pressure, and possibly improves motility, although there is a risk of new onset diplopia. Radiotherapy does not have a clear role in the treatment of DON. It might be useful for patients refractory to IV steroids who are poor surgical candidates or who refuse surgery. And we should look out for new therapeutic options, including teprotumumab, an IGF-1 receptor antibody, which is safe and effective in the treatment of Graves' neuropathy and has shown some promising results in DON, or JAK inhibitors, which may suppress the inflammatory cascade in Graves' neuropathy. But as usual, further studies are needed to reconfirm the efficacy and safety of these compounds. So in conclusion, DON is a sight-threatening emergency. There are no clear diagnostic criteria, so we should rely on clinical and radiologic signs. Prompt treatment is necessary, and the first line is IV steroids, and the visual function or the loss of visual function is mostly reversible if we act early and appropriately. Thank you for your time, and if there are any questions, please shoot.